All right, welcome everybody. Thank you for being here. We are so excited to have you here today. Let's see, I just need to get myself set up here. So give me just 2 seconds. I always struggle with the technology. All right. I think we're there. So I'm going to turn it over to Lynette on deck, who is the chair of our steering committee, to open us up today. Lynette.
Yes, good morning. Go ahead and, yep, there we go. We want to begin by acknowledging with humility that the land where we are today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, shorelines, valleys, and mountains of the traditional homeland of the Coast Salish people since time immemorial. And just a quick reminder about the mission of the Oral Health LIN. The mission of the North Sound Oral Health LIN is to create innovative partnerships and sustainable strategies to increase oral health equity and improve the quality of life for all people in the North Sound region. And as Lisa said, I am the chair of the North Sound Oral Health LIN, but I am also a school nurse corps administrator. I work at the ESD Northwest Educational Service District in Anacortes, and I would like to welcome you all to today's all LIN meeting, and I'm excited to see and hear about the projects that we're going to review today and just have a discussion. So with that, I'll turn it back to Lisa.
Thanks so much, Lynette. All right, so let's just quickly review what today is going to look like. So I'm going to begin by kind of doing some network grounding so that we're all on the same page. We'll have some opportunities for networking. Then we've got 2 great projects that we want to share about with you all today. And then we'll spend some time doing some network input sessions. So we'll be really tapping you for your wonderful and great ideas. And then we'll move to close out the meeting with some next steps. So that's what today is going to look like. And of course, if you have any questions, you can put them in the chat. And then if you could please introduce yourselves in the chat with your name, pronouns, title, and organization, so we know who all is in the room together. All right, and then we'll go ahead, and while you're doing that, I'll get us started. So we're ready for the next slide. All right, so since we have probably a lot of new folks and we only meet a couple times a year, I wanted to take a little bit of time at the beginning of this meeting just to refresh everybody's memory about what the LIN is. So the LIN stands for Local Impact Network, but you will hear LIN because Local Impact Network is quite a mouthful. But simply put, the LIN is a partnership of organizations within the North Sound region that are dedicated to improving oral health equity by sharing resources, data, knowledge, capacity, and so on, as well as partnering on projects together. We're led by a steering committee who sets the strategic direction and approves the project proposals. And the LIN is supported by the Arcora Foundation and the North Sound ACH, who both commit resources to make the network possible. And the most important thing that I really want to share here is that the LIN is built on a collaborative model. And so while Arcora contributes funds and my role through the ACH coordinates the network, the work is really guided by all of you in the network. So the input you provide at these meetings, one-on-one discussions that we have, and the projects that get submitted into the network to see realized. All right, next slide. And so the reason that this network is so important is that we have an oral health epidemic that affects a large part of the population. And it's often called the silent epidemic because despite being largely preventable, caries that are commonly called cavities and periodontal disease are among the most chronic conditions in the US, and they have far-reaching impacts. We know that children's ability to learn, adults' ability to become employed, and general quality of life are impacted, not to mention the linkages with other serious chronic diseases, which are exacerbated by lack of oral health care. So while there are many factors that contribute to these outcomes, like insurance systems, the medical dental divide, institutional inequities, and so much more, all of this is creating inefficiencies and additional costs throughout the healthcare systems and well beyond. So the next slide, the LIN really focuses its work around 5 anchor strategies that are mutually reinforcing. The first of which I really see as an overarching strategy, which is access to care. And this is really about identifying appropriate access pathways for underserved populations, testing new models of care, and having a goal ultimately of increasing Medicaid utilization rates. And so 3 primary strategies have emerged as promising pathways to do this. And so these are mobile dental, which focuses on bringing the care to the people who need it most. And this includes both the geographically isolated areas, but also specific and targeted populations who have historically not received care and need a different mechanism to engage, especially around preventative care. And while there are many models within the realm of mobile dental care that serve a multitude of populations, school sealant programs and emergency services, such as those provided by Medical Teams International, are what we most commonly know. But in actuality, mobile dental services can look a variety of ways and provide a spectrum of services. And we're going to learn a little bit more about that later in the meeting. Oral health integration provides preventative services in other healthcare settings, but it also includes training providers, frontline workers, and other trusted messengers so they can help educate people about positive oral health behaviors and be that connector to the providers for routine care. Workforce, another vital strategy, because like most other healthcare professions, there are serious staffing shortages in this sector. So focusing on how we can increase capacity by strengthening the student pipeline into these careers, with a particular focus on living wage certificate programs like dental assistants, registered dental hygienists, and now more broadly in Washington State, a big celebration, dental therapists. Additionally, we need to consider strategies that combat burnout and workforce loss, because maintaining the current workforce is equally important. And then finally, oral health education, which I really see is what underscores everything, all of these strategies, really. Thinking about how we promote not only the messages to influence positive health behavior, but how do we shift community norms and break down the silos around oral health generally? All right. So I just want to show you a little bit of data here that really demonstrates why we need these alternative strategies to expand access. These numbers here represent the ratio of population to dentists in each of the 5 North Sound counties. And as of 2021, most of the North Sound region, and there are some exceptions in Snohomish County, were designated as either dental health professional shortage areas or dental health professional high needs shortage areas. So this makes it really clear that the existing workforce is not sufficient to meet the needs of our population here. Therefore, increased focus on prevention by building diverse teams of allies and educators and early detection specialists needs to be a primary focus of our work. Next slide. All right. So here is what the LIN is striving for. So both within the network and through the projects that we fund are our network pillars. And those are collaboration, systems change, and sustainability with equity woven throughout. So collaboration is about bringing together partners to share resources, knowledge, capacity, and more, so that together we can do what might not be possible individually. Collaboration with an equity lens allows us to intentionally redistribute resources to the areas of greatest need. Systems change acknowledges that we need alternative solutions to meet the complex and differing needs of the whole community. Our systems, unfortunately, were designed to leave people out, and therefore we need to design new pathways to address the unique barriers and conditions of different populations within our region. And sustainability is about investing in partnerships and solutions that can adapt over time to be integrated into existing roles and organizations or systems, funding sources, what have you, so that the social and cultural capacity built throughout this network and the projects can continue to thrive. We don't want to cause more harm or damage relationships by building programs that just disappear once LIN funds are no longer available. So now that you all have a very firm understanding of what we hope to accomplish here in the LIN, we're going to switch gears and spend some time getting to know each other so that we can have those connections needed to make this work possible. So Natalie is going to put us into breakout rooms for 6 minutes. There'll be 3 people in each room. Introduce yourself, and we're going to put our question in the chat, which is, what is the wallpaper picture on your phone and why? So we'll also broadcast every 2 minutes, so you know to switch speakers so everybody gets an opportunity. All right, so we'll see you in the rooms. All right, welcome back, everyone. Oh, let's try that again. Goodness, technical difficulties. Welcome back. The 3rd time is a charm. Hopefully you had fun chatting. I learned about a new animal that I had never heard about called the tarsier. So check it out, both very ugly and very cute at the same time. And I realized I didn't introduce myself, I don't think. So if I did, I apologize. My name is Lisa Sony, and I'm the network manager for the North Sound LIN. And I've been in this role in next month 2 years, and I can't believe how quickly the time has flown by. All right. We're going to move right along and move into our first project presentation. And I'm really excited about this. Laura Welker, some of you may know her. She currently runs her own consultancy business called Laura Welker Consulting, but previously was at WAHA, Whatcom Alliance for Health Advancement, where I think her interest in oral health was sparked, and she has been such an amazing partner throughout this last year, and I'm really excited that we're going to continue to work together into 2024. So she did a mobile feasibility study for us because we're recognizing the need. And so she's going to share the results with you now. So Laura, take it away.
Hi, everyone. Great to be here with you this morning. Laura Welker. And I will actually say that my interest in oral health started when I was a health educator at CMAR back in the early 90s. But I did do quite a lot of work around oral health access when I was at Whatcom Alliance for Health Advancement as well. So I'm excited to share the highlights from some research that I did on behalf of the LIN this last spring. And we'll just dive right in. Next slide, please. So I'm going to hit on some of the key findings, and then the rest of the presentation will be delving into these a little bit more in more detail. So some of the key things that came out from the research, which was based on online research, literature review, and interviews with mobile programs in Washington State, were mobile healthcare is really on the rise, not just dental care, medical and other areas as well. And that was partly fueled by COVID and the very mobile response to COVID vaccination. But also in the last few decades, there's been much more emphasis on health disparities and equity in healthcare that has also fueled the rise in a mobile healthcare approach. We also really saw that there's a whole variety of mobile dental models and equipment. Lisa referenced this, and I'll share today a little bit more detail about that range. Some better understanding about what is a dental home, and that it really is about services and relationships, not a location or a building. There are some unique benefits that mobile programs have. There are some keys to mobile program success that seem to hold true across all types of mobile programs. And then I'll touch a little bit on the findings around dental needs in the North Sound area. And it was quite clear that adults really were the highest need. So as I said, mobile programs are increasing across the country. There are 13 mobile programs in Washington State that were identified through this research, possibly more, especially we might have missed a few in the private sector. And they operate in a whole range of settings, from schools to early learning centers, elder care facilities, and a whole range of community sites. And through the literature, it's quite clear that mobile dental programs are considered a best practice for increasing access to dental care. So I want to talk a little bit about mobile dental equipment. And as Lisa said earlier in the introduction, mobile dental is about taking dental care to where people are. That's the basic core of it. How that happens can be quite varied. And I want to distinguish between portable dental equipment, or portal operatories, and mobile dental units, which are the drivable vans. Next slide. And so there's those kind of two basic categories of the how. And then there is also, within each of those categories, there's a whole range. So portable dental equipment can be large and complex, like these photos on the left, where these are full operatories that are transported in semis. Once they're set up, they have basically all the same equipment that you would find in a fixed site practice or clinic. Or portable equipment can be small and simple and carried in a simple van, like these ones from Unity Care Northwest here in Whatcom County. And the equipment can be quite simple. I don't know if you can see the photo on the, let's see, the second from the right, where you see the little kids' tennis shoes. That chair, if you look closely at the lacings, is just a patio lounge chair. It's not a fancy chair. And the photo to the right of that, where the provider is seeing an older woman, is just set up, it looks like, in somebody's office. I want to make clear that the two photos below the Unity Care vans aren't the Unity Care program. I just wanted to show their vehicles. So the point being here that portable equipment comes in a whole range of fancy to very simple. And what kind of portable equipment is used depends on a whole variety of things, including who's being served, budget, distance, all kinds of things. Next slide. And then drivable units. Here we have Medical Teams International. I saw Chanda on the call. Nice to see your name. Drivable units generally have 2 to 4 chairs or operatories inside the vehicle. Often there's storage space. They come with X-ray and sterilization within the unit. And obviously these are self-contained units that drive from place to place. The unit on the right is Peninsula Community Health that operates on the Kitsap Peninsula, and they have recently, really only the last few years, added dental to their mobile services. Go ahead. So the next thing I want to do before we go any further is address a concern that comes up a lot when talking about mobile dental, and that is this concern: it's not a dental home. A mobile dental care isn't a dental home. And the American Academy of Pediatric Dentistry defines a dental home as addressing anticipatory guidance and preventive, acute, and comprehensive care, and including referral to dental specialists when needed. So you see nowhere in that definition a reference to it being stationary or a building of any kind. So really, a dental home is defined by the care, the relationship, and the systems that support that care and relationship. And one key takeaway from this research is that this concept of a dental home can be accomplished with some mobile models if they're designed to do that. So I really want to convey and sort of separate out mobile dental from not being a dental home. Next slide. And another key point is that a building isn't necessarily a dental home because of the way people, especially low-income folks, use dental care. So even at a brick and mortar clinic, some people will be getting incomplete or inconsistent care there. They may go infrequently, only if they really need to. They might get some of the care they need there, but not all of it. Maybe they need 5 fillings, but they can only afford 1. And they may seek services at multiple clinics or multiple practices based on cost or convenience or other reasons. So in and of itself, a brick and mortar site doesn't constitute a dental home. Next slide. So one way to think about what I've started calling informally dental homeness is on a continuum. And at the left there, you see characteristics that are just less dental homey. So more infrequent care, maybe an inconsistent relationship with the providers or the clinic, limited services, lack of continuity, fewer referrals. And then on the more dental homey end to the right, you see regular dental care, a consistent provider relationship, more comprehensive services, etc. And the point here is that both brick and mortar clinics and mobile programs can operate anywhere along this continuum, depending on how they are designed to operate and how they're designed to serve people. Next slide, please. So I want to touch on some of the unique benefits of mobile programs that came out really clearly in the research. There can be a shift in the power imbalance between patients and the quote unquote systems in mobile dental programs, especially for people who've been more marginalized by the healthcare system and who may experience lack of control of their care. So in general, the population that mobile dental programs are more likely to serve. Going to community locations rather than expecting people to go to services communicates, a real, we care about you, we're going to go to where you are, which some people, patients find reassuring and inviting. The smaller, more private space with fewer providers and other patients really shifts the dynamic, and increasing patients' comfort can really be increased by getting care in a familiar community location, in a community center that they go to anyway, or in the gym at their kids' school, or a church that they participate in or know about. And a real key thing here that I'll touch on more later is there's a definite increase in trust when mobile programs partner with trusted community organizations that really facilitates community members accessing mobile care. It's also, many programs talk about a more low-key environment that a mobile program provides, partly because it is so much smaller scale. And this can be especially helpful for patients with behavioral health issues or if they experience dental anxiety. And then, of course, I think a benefit that we're most likely to think about, which is reducing transportation barriers and the time and the cost involved. So part of the benefit of a mobile program is partly taking the care to where people are, but it's also delivering care in a different setting and in a different way. Next slide, please. Some of the keys to mobile program success that came out of the interviews and that of Washington State programs, and then looking at programs across the country, these seem to be sort of key ingredients, if you will. That is having a paid staff team that's hired and trained for a mobile program, as opposed to maybe borrowing from a fixed site clinic or borrowing from a fixed site clinic or using volunteers. Strong partnerships and collaboration being one of the pillars of the LIN, as Lisa was speaking to. Consistency in relationships and service delivery is really, really key. And then Medicaid reimbursement is an absolutely critical element to another pillar that Lisa spoke about, the sustainability. And federally qualified health centers, FQHCs, and tribal clinics are financially well positioned in Washington State to operate mobile programs because they receive higher Medicaid reimbursement. And I'll go into this a little bit more further on. Next slide. So there's a lot of information on this slide in regards to staffing, but the key takeaway here is that hiring and training staff specific to work on the mobile program is really valuable. That said, it's challenging. And I think we all know that hiring and retaining all kinds of clinical staff in dentistry is a big challenge right now. And mobile programs have unique demands on its clinical and non-clinical staff. It's a small team. They have to work in a small space. They have to double up on the roles they're playing. The irregular schedule isn't for everyone, etc. So the key takeaway here is that Dedicated staffing is ideal. Staffing can be challenging, and staffing continuity is very important. So there's kind of a mix here. There's a dynamic tension in the area of staffing about the challenges and how critical it is to mobile programs. Next slide. I really want to hit on the partnerships and collaboration, partly because it is a LIN pillar, but also because community partnerships as a key facet of mobile programs came out so loud and clear in all of the research. And the role of community partnerships with a range of entities is just critical. Community partners can be the trusted messenger, the linkage to the dental service, and really may make a difference in terms of whether or not a person uses that service or not. Community partners are essential for providing the physical space, whether it's inside a building with portable equipment or appropriate parking areas for a drivable unit. And then they provide critical other functions like outreach and advertising, scheduling, reminder calls, et cetera, et cetera. There are other types of important partnerships, like internal partnerships within the lead organization that is running the mobile program, referral partnerships, and funding partnerships. But I really, really wanted to highlight these community partnerships. All the programs that I talked to said their program would not be successful without this element, that it's really critical. Next slide. In terms of service delivery, regardless of whether the program is providing sealants or more comprehensive care, consistent schedule and locations was a big takeaway, and this is a key thing that contributes to a program being more towards the dental home end of the continuum. The continuity with staff members, both clinical and other staff, is really critical. And again, this partnership with trusted community organizations is a key part of consistency. Next slide. Talking a little bit about funding and sustainability here. So this again is just as key findings from the research. Mobile programs are not inexpensive, and drivable units with 2, 3, 4 operatories cost about $500,000 to purchase. It can be more, could be less, especially if it's a used unit. There are some used units on the market now. Adding dental operatories can add significant cost. And then programs in general cost $400,000 to $500,000 per year to equip staff and operate, approximately. I do want to say that mobile units and portable operatories are still less expensive in general than fixed site dental clinics. So they have a price tag. They are still less expensive than purchasing or outfitting a fixed site dental clinic. In terms of funding and revenue sources, Medicaid reimbursement was a really important source of revenue for most, though not all, of the mobile programs interviewed in Washington state. And for the federally qualified community health centers operating mobile programs, Medicaid reimbursement is the primary source of funding. As I mentioned earlier, FQHCs and tribal clinics have higher Medicaid reimbursement rates. So, and I'll have another slide on that. And then it is important to not rely solely on Medicaid funding. So additional resources are reimbursement from other insurance, self-pay fees, grants, sponsorships, etc. Next slide. This is a comparison of, in Washington state, Medicaid dental reimbursement, a comparison of private providers, which is in the gray column, federally qualified health centers in the yellow column, and then tribal dental clinics in kind of the peach colored column. And private dental providers are reimbursed on a fee for service basis. So the amount they're reimbursed depends on the specific services they provide. Federally qualified health centers and tribal clinics are reimbursed on an encounter basis. So the payment they receive is per visit. And that's why in the gray column, the amount varies based on the age of the patient and the types of services they provide. But what you can see is that in all four of these scenarios, the amount that a private dental provider is receiving for that visit and those services is less, and in some cases considerably less than what the FQHC dental clinic is reimbursed and what the tribal clinic is reimbursed. So the point here is that we often hear about the Medicaid reimbursements being so low, and that is often in reference to private dental provider reimbursement. The reimbursement rates for FQHCs and tribal clinics is higher. I do want to point out that federally qualified health centers don't all receive the exact same reimbursement. It's a little bit different for each organization. This 272 in this column is the average encounter rate for the 3 FQHCs in the North Sound region. So CHC Snohomish, CMAR, and Unity Care Northwest. So this is the reason that for mobile dental programs for which Medicaid reimbursement is so important, why I say that one of the key findings from this study is that FQHCs and tribal clinics are especially well positioned to be a lead organization for operating mobile programs. Next slide. A little bit about dental need in the North Sound, and there's quite a bit more information about this in the report, which I know the LIN will make available to everyone. In the North Sound region, lower income adults have the greatest unmet dental care needs. I think that probably is not surprising to most of you on the call. They're less likely to have Medicaid than children are. They're much more likely to have extensive and complex needs. And there's many fewer dentists or clinics that actually will see adults with Medicaid at all. So the report has more detail about this. Next slide. Yeah. So in 2021, in all of the 5 counties in the North Sound region, less than 20% of adults with Medicaid had any dental care in the previous year. And San Juan County adults with Medicaid had less than 10% of adults in San Juan County had any dental care. Next slide. Another way of looking at need is community perception, and this is a technique called service gap analysis, which hears from low-income households about the relative importance and availability of services. I see the font on here is quite small, but for all of the counties in the North Sound region, dental care is considered by low-income households to be very important and very hard to get. Next slide. This is the same analysis for both Skagit County and Snohomish County, and you can see they're all in that upper left quadrant of availability and importance. Much more detail on this in the report itself. Next slide. So the key overall takeaway to all of this is that more mobile programs in the North Sound region could be one way to increase access to dental care for lower income adults in the North Sound region. It's certainly not the only way. It has some challenges and it certainly has some costs involved. I don't want to imply that it would be, a quick or an easy fix, but it is a strategy that is working well already across the state and across the country and could be increased for the North Sound region. And I think the report URL maybe was already shared or will be at some point. That's it.
All right. Thank you so much, Laura. If you have questions, we're going to do this just in the interest of time, and we are going to have breakouts. Mobile dental will be one of them. So another opportunity to discuss. Please put questions in the chat, and then we'll be sure to get some answers out. But we have a lot on the agenda today, so I'm sorry to not open it up for questions unless there. Yes, Lainey, we will give you not only a copy of the presentation, but the report, which has all of the numbers that Lara shared. Sorry, I keep saying her name wrong. Okay, thank you so much. Let's switch gears, and now I'd like to introduce two other folks who will be presenting on a LIN project in San Juan County. So Kristen Rezabek, who is the Health and Nutrition Coordinator, and I like to say all-around dental champion of San Juan County. She works for the San Juan Health and Community Services, along with Dr. Sue Yoon, who's the Chief Dental Officer at Community Health Centers of Snohomish County. I think of these ladies as the dynamic duo. They're both on our steering committee, and they have really brought the spirit of the LIN to life with this project. So I will turn it over. Thank you.
Oh, Kristen, I think you're muted.
Let me unmute myself, and hopefully you're seeing the right screen, not the one with notes. So anyway, yeah, thank you. Thank you, Lisa, and thank you to the LIN. And Dr. Yoon and I are really pleased to be able to share just a little bit about a project that the LIN funded. So here in San Juan, where we were able to partner with Community Health Centers of Snohomish to do a school-based sealant program. So and I think from this, we really just think about kind of the building these new and innovative partnerships to meet the needs of the San Juans. And Laura sort of illustrated a little bit about some of those needs that we're experiencing in our community. And certainly this project was really kind of a proof of concept to demonstrate the feasibility of this type of partnership, working with a federally qualified health center to provide mobile dental services and see if this is feasible and sustainable. So, and Dr. Yoon, I don't want to, we're kind of sharing a little bit of this slide, so wanted to also let you.
Sure. Thank you so much, Kristen. And I think Lisa did great with our introductions, and so the audience has an idea of who we are. So let's jump right into it.
Okay. Let me see if it's going to do. Oh, it's transitioning. Hopefully, there we go. Yeah, so for this one, really was kind of around the one of our primary anchor strategies of improving access to care in our rural community, of which we're pretty geographically isolated. I think everybody's quite familiar with San Juan, and it is predominantly accessed either via the ferry or boat or plane. So really difficult. And then of course, we're coupled with an extreme shortage of Medicaid providers. In fact, we only have one currently Medicaid provider on San Juan Island, but does not see children beyond the age of 7. So the goal of this project was to try and serve all students from kind of pre-K through 12th grade in 3 of our school districts on San Juan, Orcas, and Lopez Island. And then obviously we also wanted to embed and weave in oral health education. And we did that with some written materials that we would share out. We did some virtual presentations in English and Spanish, which we'll touch base on. And then of course doing in-person And then students were sent home with oral health materials and toothbrushes, toothpaste, floss, all of that. But the big initiative was how can we bring not only screening to really identify sort of the extent of the problem and kind of define that, but then also partner with community health centers up Snohomish for actual treatment and bringing both sealants and oral hygiene in a school-based setting. So. Okay. And then I just wanted to share, and I think you got a little bit of a snippet, actually, a sneak peek from Laura's presentation. And this is from 2020 data around Apple Health utilization, but really found that San Juan County has the lowest rate of utilization in the state for all ages. It's about 24% that are actually able to access dental care for those who are on Apple Health. And obviously that's due to the shortage of providers accepting Medicaid patients. And what we found is that was really even exacerbated with COVID and post-COVID, because a lot of the providers off island that were accepting patients like Playhouse Dental and others in the Anacortes area, which would be the shortest drive for our community members, also started restricting patients or capping the ages that they were seeing. So we were really experiencing some real challenges. And you can kind of see here for ages 20 and under for San Juan, it's about a 49% dental utilization. It's only about half of our kids are actually able on Medicaid are actually able to use dental service. And the average expenditure per child was about $298, and that's on that 2020 data. And then, of course, our Prosperity Project, which was the 2018 report, found that San Juan was identified as a very high need for accessing affordable dental care. So those are just to kind of ground in some of the background when Dr. Yoon and I started to talk about this project. So collaboration, and I kind of want to let Dr. Yoon sort of lead off in terms of sort of what inspired this pilot project, looking at oral health needs and preventative hygiene practices.
Yeah, I will say that this project and this level of collaboration was several years in the making, and as Lisa mentioned, collaboration really is a critical network pillar. And then as Lara mentioned, that without this partnership, then it's really impossible to bring two different organizations together, especially with geographic separation. And so Kristen and I came to work together through the LIN, through the convenings that the North Sound ACH brought together, and then even more so as Kristen and I both serve on the steering committee. And so these are regular monthly or quarterly virtual sessions where we came to really understand each other's organizations and our commitment to oral health. And so as we're looking through the access and the utilization data, collectively, the North Sound ACH was able to say that the San Juan counties are really underserved, and that's not surprising. They're geographically isolated, and so we thought, okay, let's think really beyond just our organizations, just beyond our counties and our direct communities, but let's think about how we can really impact the entire North Sound. And so the need became apparent, and then that was at the same time where, you know, as a health center pre-COVID, we already had a framework for outreach work in our local schools, and through COVID, different school districts were ready to re-engage at different levels, and yet in our 6 brick and mortar dental clinics, we were seeing how incredibly impactful the pandemic was to the oral health of especially young children when school was all remote for a year, and all of that time at home and access to ample snacking and grazing, and sometimes not the healthiest of habits, that really had an impact. And that was the feedback we were hearing from our local school nurse partners too, that they were noticing more absenteeism due to dental related issues once the schools did reopen. So we were really committed to doing something to meet this need. And so through initial brainstorming of, hey, there's this need, hey, we have a mobile program, how could we develop something that would work? And so we worked up a grant proposal to the steering committee, and we're able to launch a program. Next slide.
And then, obviously we really wanted to make sure that we were going through and compiling kind of best practices, gleaning information, not just from Community Health Centers of Snohomish, is a successful program, but also from other programs around the state. So we've certainly take a look at the school-based sealant toolkit that's available. I did a number of different interviews with different providers. And I just want to give a real shout out to Lauren Spiles, who's the ABC coordinator and also leads the school-based sealant programs in the Benton Franklin Health District. And then certainly Beth Sennell, the King County School-Based Sealant program coordinator down there. All of those connections really kind of helped inform how we were going to develop our own program. And I will say that many of them were very welcoming in sharing out program information, whether it was their consent forms or their smile report cards or education materials. So it was really nice. We didn't have to necessarily reinvent the wheel. There was a lot that we could kind of take and pull together and adapt to meet our own program needs. And then we also were really fortunate to be able to partner through this grant with 5 of our local dental hygienists, because we wanted to go in and do screening within the schools just to really capture some of the need that anecdotally we were hearing about, but really to kind of further define that as part of this project. And so we were able to pay them stipends to participate. And that was really wonderful. And I'll share a little bit more in some of our later slides about some of the screening data that we had. At the same time, the SMILE survey was going on around the state, and we did engage with their team, thinking this would be a wonderful opportunity to help capture some of the data and the metrics as part of their SMILE survey. And I will say, ultimately, unfortunately, that was not a successful effort. A big piece of it is they had pretty short notice for our local dental hygienist to travel to an in-person calibration training. So that just was not feasible. And then when we had set our screening dates and hoping to maybe partner with a calibrated SMILE survey screener, they basically determined that it would have to be a separate, so there would have to be basically each child would not only rotate through our screening, but then they would have to rotate through the calibrated screener, that they weren't able. We were kind of hoping to be able to have them do their data piece, and then we'd have a note taker to fill out our SMILE report card, so that it was going to be equivalent. But it just didn't work out to be. It was not going to be efficient. So we did not ultimately end up doing that. But there was definitely a lot of engagement, thinking about, could there be some efficiencies created by being able to do both? And obviously they were only screening a specific population, and we were trying to screen the entire school. So we were trying to do pre-K through 12. And then I would say the last partner, the Smile Mobile, who has been really wonderful in prioritizing our community, coming out once or twice a year. They ultimately were able to come out post-screening to serve children on Orcas Island. So those are just some of our collaboration partners that we worked with on this project. And then some of the processes, and I'll just kind of go through just really briefly. We sort of had 4 phases for this project. Certainly a big piece of it with a lot of the planning efforts that we were doing. We were able to recruit those dental hygienists locally to be able to contract with them and do background checks and set up those contracts for the screening. We obviously had to establish and have memorandums of understanding with each of our 3 school districts. There were numerous planning meetings And I will say that our school nurses were really integral, along with our administrators, to make this partnership happen. And then, of course, conducting that with the Community Health Center of Snohomish team. So we really felt like we were creating something that that would be, very efficient and streamlined for their staff when they came out to visit, because it's a big trek to come up to the islands, for sure. And then with the second phase, we had our screening dates that we made sure to do a big promotion with that. I'll share a little bit about some of our social media metrics. So we were pushing things out through the press releases, through the school districts, parent letters home, and email engagement with parents and social media. And then a big piece of this is we did opt-out consent forms for our screening dates. And that'll be critical as we think about some of these program pieces moving forward, the opting out for consent. And I'll let Dr. Yoon kind of talk about sort of our third and fourth phase in terms of the provider treatment, and then of course our data collection components.
Yeah, for the dates where the CHC team came out to the islands prior to the actual screening and sealant and fluoride application, we had collected opt-in active consent forms. And I will say Kristen and her team locally on the islands were integral in that. Obviously, if we as an unknown entity to the local community just push something out, there would not be that trust and level of engagement. But Kristen and her team were such ideal partners in this collaboration, in that they were that local trusted entity that was equally invested into the success of the program, but also just the commitment to oral health. And so that was a huge piece. Kristen also helped us to arrange virtual oral health presentations that we provided live stream, and to better meet the needs of the local community. It was presented one night in English and one night in Spanish. And so there were some good lessons learned there as well.
So this slide just kind of shows two of our Heather and Erin, two of our local dental hygienists. We are set up at the Lopez Island School and kind of their little community room there. And you'll see the children come in and circle through the chairs. And then we have two note takers. So that was kind of our process for screening. And then each child, and I will say one of the pieces, and again, gleaning information from some other teams, a lot of them were filling out paper forms. And then there was like a kind of a triplicate that they would do. And then they would data enter all of those paper forms. And that seemed like we could be efficient if we could get those into an online. And so we actually did. We were able to take, this is adapted from the Benton Franklin form, and we were able to take this form and actually work with our IT team and convert it into an online format. And then we actually, with our note takers, each dental hygienist had a note taker that was basically filling in as they were looking in the child's mouth. It takes less than a minute. It's pretty quick and easy. And then we were able to, through our iPads, enter all that information digitally, which was great. So there were some pieces here that I think were super beneficial. Our one lesson learned, I will say, is that we had a Wi-Fi enabled printer. And that was like one of our big hiccups, was trying to be able to print the forms quickly. Like they were so fast that we couldn't get the forms printed out fast enough to give to students to take home. And so there's some things where we thought, it'd probably be better if we can just email these in the future. So there's some pieces of this where we're like, okay, we can further refine these processes. But I just wanted to highlight, a lot of people have said, schools don't like to pull kids out of classroom and class time. And what we heard like overwhelmingly from teachers who would bring the students in is just appreciation that we were doing this, and like so much gratitude and thankfulness from the school administrators, from the not only the principals and the teachers, but just like hearing back from parents that they were really grateful that we were in the schools, that we were taking a look in children's mouth to identify any oral health issues or challenges. So it was really nice to get that feedback. This is some of our screening data here. And so you'll see this is kind of broken down by our 3 school districts and then totals. And for the total, what we found is that out of the total students we saw, which were 748, about 43% of those students needed at least one or more sealants. So this is not number of teeth that need to be sealed. These are just students who, on that initial screening date, the dental hygienist identified a potential need for sealants to be placed. And so that was great for us to kind of understand the scope of the problem. Is like it was 43% of students that we screened. And then we also found as part of that is for students they identified as kind of a more urgent need for cleaning. That was about 18-20% of students who are needing that. And about 9% needed to see the dentist. And then about 3%, 24 students really had more urgent needs that couldn't wait, that needed to be seen. And then there were 23 that they indicated had some orthodontia concerns. We had been hoping to screen over 1,000 students. And so I just want to highlight this actually does not include the high school students. Unfortunately, both San Juan and Orcas High School, the principals for those schools felt like it was too challenging for us to be able to bring high school students through and do screenings. And so they decided instead of an opt-out that they would opt in. And the big difference is that we only saw 5 students from the Orcas High School and no students from the Friday Harbor High School. So I think it just goes to show opt-in versus opt-out, kind of the dramatic components, at least from a screening program. And then I'll let Sue kind of speak to what her team did, because we were really excited to have them come out to the islands. And you'll see this is the mobile chair, more expensive than that lawn chair that you highlighted, Lara. I will say that. But this was some of the mobile equipment that the county actually purchased to support this program.
And that's actually a small example of the level of partnership and commitment to meet all the needs. Once we started getting into the logistics of how do we get our team up there, even things like trunk space for all the supplies we need to bring, that patient chair does fold down pretty compact, but it takes up a good amount of space, and so we had just thrown it out there to Kristen and her team. Could something be purchased that just is kept up there? And they were able to act on that quickly so that our team could focus on just the disposable dental materials that we needed to bring, which we wanted to make sure that we had ample supply of in case there were last minute students that turned in consent forms, and we didn't have the luxury of just being able to run to one of our local clinics and grab more sealant material or something. So we came well stocked. But I think it's worth mentioning that this project did involve a lot of planning and logistics of details, from ferry reservations, how much equipment and supplies to bring. The community, the local San Juan community, provided lodging, and so just coordinating with these generous homeowners and making sure that we sign liability forms and things. One of the hurdles we had to work through was around how to handle our hourly support staff doing an overnight on the islands. It's just something we've never had to navigate before locally, but we worked through that, and overall it was so rewarding. The teams that did participate really enjoyed it. I mean, who doesn't love an opportunity to go up to the islands? So all around really positive. Next slide shows some of the actual sealant data that.
And I'll click over there. I just wanted to highlight a couple of things on this one. When people talk about, so oftentimes the perception of the San Juans is that we're a very wealthy enclave and poor people don't exist in our community, which is not true. So I just wanted to highlight just some quick numbers so that people can see that for the free and reduced school lunch program, which is kind of how we capture some of that data, our elementary school is at 38% free and reduced. Our middle school is almost at 50, so 49%. The Orcas Elementary was at 38%. And then our entire Lopez School District actually is at 63%. So when we kind of think about that and the students we're serving with that equity piece, and then about a quarter of the students that we're seeing within each of these school districts is a Latinx student. So anyway, just wanted to kind of briefly highlight those because I always like to sort of correct some of the misperceptions sometimes of our community. All right, this is the one that, well, this is the nitty gritty, which is very exciting.
Yes. This outlines the students that receive services and then how many sealants were actually applied to individual molars. For those that maybe don't have a clinical background, sealants are one of the most proven preventative strategies that we have in dentistry. It reduces the risk of that tooth getting a cavity by about 80%. And so for me as a provider, I am passionate about sealing every single healthy virgin molar that we can before it even has an opportunity to get a cavity, because the intervention is so impactful. So we're really proud of these numbers, and the total of 459 molars getting sealed is in combination with our team's efforts, as well as the Smile Mobile that was out on Orcas Island a few weeks before we came out. And then, as Lisa mentioned, again, one of the pillars of the LIN is around real systems change. Kristen, I think you were going to take the first two there.
I think so. Yeah. So again, this is the pilot.
Ladies, I'm just going to interrupt real quick. We just have a couple minutes. So
oh, we're almost done. I promise.
Okay, no worries.
Okay. So again, this was just that pilot project, bringing that mobile dental solution with the school-based sealant program. So we won't continue to highlight that piece. And I think a big part was the partnership and the rapport that the health department had established with the schools is really sort of enabled us to sort of lead in with community health centers of Snohomish. I think without some of those pieces, if like a school-based sealant program that didn't have that connection with the health department, it would have been a little harder to gain traction within the schools. And that's understandable, right? They want to know whom they're working with, particularly when they're opening up their students and their doors to providers coming in.
And then another commitment on our part was that the patients had a pathway for continuity of care. Once they're identified as having a large dental need, then Kristen was able to she has awareness around where the local referral options are, and so there was good warm handoff on that. And then what we could bring as an FQHC was the billing piece, as sustainability, of course, is an important component. And then, as mentioned, the local San Juan community helped offset some of the lodging and transportation costs that would have been otherwise incurred.
This is our second to last slide, I promise, Lisa.
So highlights there, and we're still working through the data to really determine the cost of the program versus reimbursement rates. But overall, with the community partnership, it is proving to be a sustainable model. And Kristen and I have already brainstormed on a lot of ideas of what we will do differently this time around, and how we can even expand the services.
Yeah, and I just wanted to very quickly kind of share out, because this is so foreign to me with social media, and I promised I'd given you that teaser, but one of the things that we had wanted to weave in is some of that oral health education, and we didn't get very many. In fact, we had no participation on that, so that was a good lesson learned of like virtual format. It doesn't really work well if we don't do it in tandem or conjunction with like an existing school night. But our communications person said, you know what, our social media metrics through the county's Facebook, Instagram, and Twitter, which is now X, I think. We did several different postings in English and Spanish, and the combined reach was like 1,679. And she said the engagement on each of those posts, and I didn't really understand these metrics, but she's like, if it's 3 to 5%, that's huge. And she said our engagement level on all of those posts was anywhere from 3 to 12.5%. So that was like amazing, I guess, in like social media world. So that was good to know. And then our virtual presentations, we actually did get 15 viewers and 12 viewers in Spanish. So Sue, that was the good news, is it wasn't totally in vain, that people did go. Not a huge amount, obviously, so we need to do more, but yeah, it was a really amazing project and a lot of good lessons learned. And yeah, we just want to thank the North Sound ECH and Oral Health LIN, and of course our Cora Foundation and Lisa. We want to express our appreciation to you. And we could not have done this without the amazing school district nurses and the administrators in our community. And of course the Community Health Center of Snohomish team and all of our health department team here. So, and that is it. I will stop sharing.
Thank you, ladies. There's always so much information to share, and I appreciate everything that you shared. I think just hearing Laura's example of kind of research, and then you all coming in, as she mentions, with this real life example really fit nicely together. So thank you, thank you. All right, we are just gonna keep going because there's so much good stuff to talk about today. We're gonna just jump right into some network input sessions. So we just stuck a lot of information into your brains, and now we want to hear from you. So in just a second, you are going to get to select a breakout room, and either mobile dental, workforce, or oral health integration. We're going to put a Jamboard in the chat. I want to say it's viewer only, because in each of these rooms, there will be a facilitator and a note taker. So you can follow along on the Jamboard if you would like, but otherwise you can just show up in the room. And the link is in there now. So we have one question that we want you all to talk about. What kinds of collaborations are needed to address this strategy? So depending on which room you're in. And I just urge you, be creative, think big, think small, just be willing to engage with your group, because everybody's perspective is really important. And then we're going to give you a bit of time for idea generation. Natalie and I are going to work that out. And then we're going to broadcast a message into your room that says, hey, let's move from generating ideas to synthesizing them. And we are going to come back in the big group and share. So we want you to think about which of these ideas are most impactful for the region, which of these ideas are most implementable. And there are a lot of variations on what that means, but you all can talk that out in your room. So with no further ado, Natalie, we're ready to launch those rooms as soon as you're ready. Okay, sorry if the timing on that was confusing. We got a little behind, so we were trying to seed a little bit more time for discussion in there. As these meetings go, sometimes you just have to pivot, and time is never our friend. So hopefully there was some rich conversation in each of the rooms. And what I really want to do very quickly is to have each of the facilitators, like a minute or less, just summarize. You don't even have to do impactful or implementable if that's not what came out of your room, but just share some highlights from y'all's discussion together. So Colette, I'm going to start with you, and just like a real brief one. Oh, you're muted.
Sorry.
That's okay.
We definitely ran out of time. We had a very lively discussion and really great experience from everyone in the room. So it was great to have the minds coming together. I can share at least what we got to our most impactful and our most like actionable or implementable idea.
And this is for oral health integration,
Sorry,
right?
for oral health integration, yes. So for most impactful, an idea was training community health workers and kind of like non-traditional medical providers, so like community paramedics, different folks to provide access to trainings about oral health and dental care. And also for an actionable idea would be connecting emergency departments, urgent care facilities, primary care settings, as well as places where folks would be accessing social services like, seeing WIC or different food programs, accessing behavioral health, connecting them to dental link, so that they could help folks locate dental providers that they could, that accept Medicaid, that they could be seen by, and that perhaps, they could give that information to people like prior to having prior to them having a dental emergency, so that they could access, preventive care.
Awesome. Thank you. And so Nika put dentist link in case anybody is wondering how you'd connect to that. It's a referral pathway in the chat. Cynthia, who was doing workforce, what is a very quick synopsis of your group?
Gosh, quick. I don't know if we can do quick, but I'm going to try. Great things came out. These are experts, and these folks have been thinking about how to do this, right? So exposure to high school, middle school, getting folks to students to understand what that workforce looks like and what the opportunities were great. One person thought about creating a pool of on-call dental oral health professionals that they can use on a as needed basis. The opportunity for the workforce, if you were a progression of experience to lead you from one position to the next. If you are an assistant, maybe that work experience could help progress you to become a hygienist and then to a dentist, and creating some systems which would have to be approved by the necessary higher people, whoever those people are, sorry, to create, but to create this pathway so that they can move forward in the profession instead of just staying in one place. If they so it was just fascinating, and I hope that the conversations can continue.
Perfect. Thank you. And Paulette, who was doing mobile dental, what were your highlights very quickly?
Well, we had some really great ideas. So top kind of implementable ideas where we thought were easily attainable, people are kind of doing this work already, was community health fairs and integrating oral health care into that. These health fairs exist, so let's just jump right into them. And then working with FQHCs and the tribal clinics to get mobile dental access to them, seeing about their interests, how that could work within their settings. There was a really interesting idea to work with the housing authority and ESC to provide services to migrant workers and their families. So that was a wonderful idea. We also discussed developing a cohort to keep engaging via facilitated meetings. So keep the conversation going where these wonderful ideas could be brought up continuously so we can keep working on them.
Great. Well, sounds like there is a lot of food for thought, if you will. So let me just bring us to what next steps are going to look like, which is, I don't have that set just yet, but there are next steps coming. So what we really want to do is take all the information that we gathered from you all today and take a look at really what was shared. I also, in a minute, am going to give you all an evaluation, and there's an opportunity there to add additional information. So I want to encourage you to do that, because I just kind of want to sift sift through everything. I do have an idea of bringing us together for those who are really interested in taking action to a series of meetings to organize ourselves to do that. But what exactly that looks like, I can't tell you today. So I can say stay tuned. It's going to happen quite quickly. But before we go, Corey is going to put that evaluation into the chat. And my ask is for you to please open it now, if you will. So it's already sitting there. It is a mere 4 questions. Your feedback just is so important and helpful, both on how these meetings are rolling out and like how we want to work together in the future. And you're all experts. So all those tidbits of information, I am also new to the oral health field. So I'm learning from everybody and all of you and need you all to help guide us in the direction that we need to go in. All right. And then in the interest of time, because I am just determined to get you all out of here on time with lunch just rolling around, we're gonna just put one last slide up, and I really like this. It comes with just this little story that was kind of one of those aha moments. And I don't know if she's still on the call, but Dr. Duback, who was formerly the dental director at Lummi, and I were having a conversation, and we were talking about, oral health. And one thing that she said to me, we're talking about all these complex systems and problems, and they are, and we need to find ways to address them. But she just really spoke to the essence. And she said, there's nothing better, this is paraphrased, than giving someone their smile back. And that just really hit home to me, because it made, all these like complicated things just so personal in that moment. And so I ended up going down a little rabbit hole about smiling, and I have a couple stats here that I found. And so what I think is so beautiful is that, yes, we can sit in the complex, but it's important to also embrace the simplicity. And we know that smiling in and of itself is a healing act for the individual. It ripples out into the community. It crosses language and cultural barriers. And so I just wanted to end on this note with this beautiful baby that is going to make everybody smile, and leave you with the question of like, how can you help us promote and integrate oral health into the work that you do every day? So I thank you all so much for being here. I have come to love oral health so much, and I'm just trying to recruit everyone. So please go out and recruit and bring more people to this network. We need everybody to do this, and stay tuned for a follow-up email with next steps. So have a wonderful day, everyone. Thank you.